This is Dr. Ben Weitz with the Rational Wellness Podcast, bringing you the cutting-edge information on health and nutrition from the latest scientific research and by interviewing the top experts in the field. Please subscribe to the Rational Wellness Podcast on iTunes and YouTube, and sign up for my free ebook on my website by going to drweitz.com. Let's get started on your road to better health.
Hello, Rational Wellness Podcasters. Thank you so much for joining me again today. For those of you who enjoy listening to the Rational Wellness Podcast, please go to your Apple Podcast app or wherever you listen, whatever podcast app you use, and give us a ratings and review. That way more people can find out about the Rational Wellness Podcast. Also, you can find a video version if you go to my YouTube page. And if you go to my website, drweitz.com, you can find a full transcript and detailed show notes. So our topic for today is how to prevent and reverse cardiovascular disease. In the 1950s and 60s, Ansel Keys and other researchers told us that eating too much fat, especially saturated fat, such as found in red meat, butter, and cheese, is the cause of heart disease. Saturated fat raises LDL levels, which leads to cholesterol buildup in the arteries. End of the story. Thus, the low-fat mantra was born as a way to prevent heart disease. Though, as we have learned after 30 or 40 years, it didn't really do all that much to prevent heart disease. We've learned that most of the cholesterol in the body is produced by the liver, and it's made from glucose. So we have learned that consumption of refined carbohydrates and sugar is a greater contributor to raise our lipids and contribute to heart disease. But did you know that inflammation in the walls of our arteries increases the likelihood of cholesterol to be found lining our arteries, what we call atherosclerosis? And that inflammation can be caused by many things, including heavy metal toxicity, pesticides, mold toxins, chronic infections, food allergies, and consuming hydrogenated vegetable oils, among other things. As we will learn today, cardiovascular disease is not just a metabolic disease, but also an immunologically mediated condition. Dr. Mark Houston is our special guest today. He's an internal medical doctor and a hypertension and cardiovascular specialist. He's the director of the Hypertension Institute in Nashville, Tennessee. Dr. Houston is triple board certified in hypertension as a fellow of the American Board of Hypertension. He's also board certified in internal medicine and anti-aging medicine. He has a master's degree in human nutrition and a master's of science degree. Dr. Houston teaches doctors around the world about cardiovascular medicine as part of the Institute of Functional Medicine and the A4M programs. Dr. Houston is also a very prolific author, having written What Your Doctor May Not Tell You About Hypertension, What Your Doctor May Not Tell You About Heart Disease, Nutritional and Integrative Strategies in Cardiovascular Medicine, Nutritional and Integrative Strategies in Cardiovascular Medicine, and his two latest books, Vascular Biology for the Clinician, which has just recently come out, and Precision and Personalized Integrative Cardiovascular Medicine, which will be out in November. Thank you so much for joining me, Dr. Houston.
Thanks, Ben. It's good to be with you.
Excellent, excellent. So can you talk about some of the specific vascular responses that cause coronary heart disease?
Absolutely. The cardiovascular world's literally been turned upside down as far as causes, insults, and how the arterial wall responds to all those insults. And as you rightly pointed out, we've been misled down the bad food path for 40 years, and now we're having to go back and reorganize our entire thinking process about that piece. But there's about 400 risk factors for coronary heart disease and atherosclerosis. Obviously, we'll talk about some of the top ones today, but the concept that I like to get across to people is that these insults that are coming in The blood vessel can't name them. It just sees what's coming in, and it may say, well, it's amino acid sequence or a fatty acid sequence. So E. coli, as far as the vessel is concerned, can look just like LDL cholesterol. And so the response is limited. It's very limited. In fact, there's only 3 things the blood vessel can do to respond to these insults. There's 3 of them called inflammation, oxidative stress, and vascular immune dysfunction. So when those 3 go off in the blood vessel, it can create all kinds of biomediators that eventually lead to coronary heart disease or congestive heart failure, stroke, or any kind of cardiovascular illness.
Recently in the news, there's been quite a bit of back and forth about the role of red meat in heart disease and cancer. With a recent paper in the Annals of Internal Medicine, where a bunch of researchers did a reanalysis of the existing research on red and processed meat and concluded that the evidence for harm from red meat was very limited and does not warrant recommending that citizens reduce their red meat and processed meat intake in order to reduce their risk of heart disease. They shot back with a reaffirmation, I think it's World Cancer Council, that you do want to reduce your intake of red and processed meat in order to reduce your risk of cancer. So we've got this back and forth on whether or not red meat is a factor in heart disease. Where do you come down on this controversy?
Well, it goes to show you can find whatever you want to in any journal, wherever you go to read it. Pardon the noise here. Let me get this. He'll be gone in just a second. Apologies. So let me try to give you the real truth about red meat. The meat is not the problem. The red meat is not the problem. It's what the red meat has in it coming from other sources related to the cow. Okay. So if you have a cattle that are eating corn, being fed bad food, giving hormones, getting pesticides and organocides and gosh knows what else into their body, that's going to go into the meat. Whereas if you get organic food and you don't put any hormones or pesticides out in what they eat, the red meat is absolutely benign and doesn't cause heart disease. So as you pointed out earlier, toxins, infections, pesticides, and hormones are probably the issue and all the bad stuff that's happened with coronary heart disease and red meat. So my opinion, based on having looked at this very carefully also in the last 2 years, organic red meat is fine to eat. And you can find numerous studies that say it does not increase coronary heart disease or heart attack.
So essentially what everybody's forgetting about is the quality of the food when we are just looking at these macronutrient discussions. You know, we're not looking at the quality of the meat. We're not looking at the quality of the carbohydrate or the quality of the fat. And so what you're saying is if we're consuming a high quality red meat that's organic from grass-fed cattle, that's going to have a totally different biochemistry and a different effect in our body than eating feedlot cattle that's shot up with antibiotics and hormones.
Exactly. So in general, what we like to do is stick with something that's fresh and organic, whether it's a vegetable or a fruit or meat or some other kind of fat. Exactly.
Right. So since we're on the topic of red meat, part of the conversation about red meat has to do with the role of saturated fat. And so what's your opinion about the role of saturated fat? Does saturated fat raise LDL cholesterol, and does it play a role in the pathogenesis of atherosclerosis?
We also have written several articles in the peer-reviewed literature as well as in the book on integrative strategies and CVDs to talk about what is really the truth about saturated fats. So this is what the literature is clearly shown now. A saturated fat is not just a saturated fat. There are different varieties within that. What determines what type of saturated fat is going to cause heart disease or not cause heart disease. And the primary issue relates to what's called carbon length. So, carbon length 8, 10, 12, and on up to whatever, 20 something. The long chain fatty acids, that is probably C12 and up, are considered long chain. Those are the ones that may have an increased risk of coronary heart disease and heart attack. But even that's somewhat questionable depending on where the fat's coming from and what's it associated with, what other kind of fats are in your diet, and the percent in your diet. But if you eat C12 and below, the short chain fatty acids, there's no evidence that any of those cause coronary heart disease or heart attack. So what I typically tell people to do is keep your total saturated fat intake around 10% or so of your total calories and try to limit it to the short chain fatty acids. It doesn't mean you can't have some long chain. It's just don't make those an abundant piece of your diet.
So which sources of saturated fat have the shorter chain?
So what you want to do is you've got to read labels. That's the problem. And labels, as you know, can be very, very deceiving. I think if you look at high quality meats of any sort, particularly if you're talking about organic red meat or organic veal, organic chicken, organic turkey, fish obviously don't have hardly any saturated fats. They're mostly monounsaturated and omega-3s, mostly omega-3s. Then you're going to end up just getting the good fats doing that alone.
So where does coconut oil fit into this? Because we know that coconut oil is a vegetable source of saturated fat, and the arguments have been going back and forth on coconut oil. Has been lauded by many in the functional medicine community as a wonder fat. And then we've got the American Heart Association still telling people not to consume coconut oil.
Yeah, that's a loaded question. The coconut oil story is also very controversial, but coconut oil is 92% saturated fat. It doesn't really have many other kind of good fats in it. So if you go out,
but is it the shorter chain or the longer chain?
No, it's the long chain. That's the problem. Okay. So it's 92% long chain fatty acids. So I wouldn't recommend you consume a lot of coconut oil for that reason. A little bit, just like what's mentioned earlier, is fine, but don't get hung up on drinking a lot of coconut oil or consuming coconuts because they're probably may not be healthy. There's really not much data, honestly, that coconut oil has any really good health benefits. But on the other hand, a lot of it could be detrimental.
Interesting, because I think a lot of people in the functional medicine world have put coconut oil in the healthy oil category.
Right. I'd much rather you consume omega-3 fatty acids and olive oil, monounsaturated fats. They're much healthier with better data. When you get the coconut oil, you kind of don't find much out there that's going to help you for heart disease.
Now, one of the reasons why people say they like coconut oil is because the saturated fat, because it's saturated, is not going to react to oxygen or other things. And so therefore, if you try to cook with a polyunsaturated oil, or you try to cook with an olive oil, it goes rancid and gets damaged. Whereas coconut oil, because it's a saturated fat, is not going to have that happen.
Another great question. What kind of oil should you cook with and why
Yes.
or why not? The Europeans really laugh at us when we say we don't cook with olive oil. They said, no, we cook with olive oil all the time. Just don't boil it, because you will destroy it. We overcook everything. So I cook with olive oil, but I don't bring it to a steaming point.
So what is the temperature cutoff?
So you get it warm, but if it starts to
what is warm? I mean, we're talking about 350.
I don't know what the boiling point of olive oil is. Well, the point is you keep it on low simmer, and when you see the olive oil starting to steam, you've gone too far. Now you can cook with other oils, obviously. Grapeseed oil is good. You could cook with olive oil, and you can cook with coconut oil. You cook all these things. Point is, just don't overcook things. And the other point is, if you want to cook with olive oil, okay, go ahead and cook with it. Pour off the olive oil if you think it's bad, and then put some olive oil on your food when you put it in your plate. That's fine.
But like, say if you look at some of these charts and they're very confusing, extra virgin olive oil has this temperature. Another chart has it, the boiling point at a different temperature. Is it 325? Is it 375? Like if you're going to say baked vegetables, do we know what a safe temperature is if you're going to use olive oil?
I don't know that I have the temperature because you'd have to put a thermometer in your pan, and even then, you're not sure with all the other stuff in the pan whether it's going to steam or not. I just tell people, just don't let it start steaming, and you're okay. Low temperature.
Right.
Saute.
What about avocado oil for high heat cooking?
Avocado oil is fine. It's a monounsaturated fat, and it'll tolerate the heat a lot better, and it's good oil to use. By
the way, since we're on monounsaturated oils, we're going to get to advanced lipid testing, but one of the companies that does advanced lipid testing now puts monounsaturated oils as less healthy. Do you know about this controversy? Yeah,
I do. I hear it all the time. And I hear a lot of physicians telling people not to use a lot of monounsaturated fats. That's also not true. Monounsaturated fats and olive oil, nuts, olives are all healthy. And there's plenty of data to support the use for them in reducing coronary heart disease. Here's the trick though, okay? What's your comparator, okay? So if I want to compare monounsaturated fats to omega-3 fatty acids, they don't look as good, okay? But if I want to compare them to saturated fats, they look really good. If I want to compare them to refined carbohydrates, they really look good. So it's just your comparator. But overall, monounsaturated fats are very healthy.
Okay, since we're on this topic, since we just talked about MUFAs, what about PUFAs?
Okay, so polyunsaturated fatty acids, those do break up in heat, okay, because they're a lot of double bonds and they can be more unstable. So how do you get around that problem? Well, two things. One, when you buy omega-3 fatty acids, you want to be sure it has a tocopherol in with it, because the vitamin E tocopherol, particularly gamma delta tocopherol, stabilizes the PUFAs or the omega-3s in the bottle. But you also need it to stabilize it in your cell membranes. So whatever you consume when you're using omega-3s, be sure that your product contains tocopherols, omega-3 DHA, EPA, but also another one, GLA, because you got to have those pathways lined up so you don't distribute them inappropriately.
Interesting. I was using the gamma tocopherol every time I took my omega-3s and was recommending it. And I recently switched over to tocotrienols after talking to Dr. Barry Tan and seeing amazing research on tocotrienols.
Yeah, I know Barry very well, and his data is incredible with all the forms of vitamin E. The tocotrienols don't necessarily stabilize polyunsaturated fats, though. They have other tremendous health benefits, and I take his gamma delta tocotrienols, but also I take the gamma delta tocopherols.
Okay, so you take them both, but just not at the same time.
It's really important for your audience. If you take your tocotrienols and your tocopherols at the same time, and it's more than 20% alpha tocopherol, it'll block the absorption of the tocotrienols. You got to take them about 12 hours apart.
Right, and when you take the tocopherols, you want a higher gamma, right? You don't want to take
you don't want a lot of alpha. You want mostly gamma and or delta.
I've really been enjoying this discussion, but I'd like to pause for a minute to tell you about our sponsor for this podcast. I'm proud that this episode of the Rational Wellness Podcast is sponsored by Integrative Therapeutics, which is one of the few lines of professional products that I use in my office. Integrative Therapeutics is a top-tier manufacturer of clinician-designed, cutting-edge nutritional products with therapeutic dosages of scientifically proven ingredients to help our patients prevent chronic diseases and feel better naturally. Integrative Therapeutics is also the founding sponsor of TAP Integrative. this is a great resource for education for practitioners. I'm a subscriber to Tap Integrative. There's videos, there's lots of great information constantly being updated and improved upon by Dr. Lee Salschuler, who runs it. One of the things I really enjoy about Tap Integrative is that it includes a service that provides you with full copies of journal articles, and it's included in the yearly annual fee. And if you use the discount code WEITZ, WEITZ, you'll be able to subscribe for only $99 for the year. And now, back to our discussion. Okay, so it's common for primary care doctors to order a basic lipid panel, which is total cholesterol, estimated LDL, HDL, and triglycerides. And sometimes in conversations with patients, they'll say, oh, yeah, I looked at all my lipids were fine. Can you explain why this lipid profile is not an adequate way to assess for heart disease risk?
Absolutely. Regular lipid testing is obsolete. Okay. Let's make that very clear. Advanced lipid testing is state of the art. And that
message has not, it either hasn't gotten out or the fact that insurance doesn't want to cover it.
Well, that's even not an issue anymore. All the advanced lipid testing companies that we use, they're covered by insurance, and if you don't, if they're not, they're like $60. So it's not that you can't afford them. But here's the really important part about advanced lipid testing. Let's take each lipid just individually because you have to do that. LDL cholesterol, different sizes, different atherogenicity. Some are modified. So let's say you have a big fat LDL and a little tiny LDL. Well, let's use a garbage can analogy because people get this. 2 garbage cans sitting in your backyard. You look at them and say, that's my LDL. And I say, well, which one's bad? And they go, well, I don't know. They're both bad, aren't they? I said, no. Take the lid off the garbage can. One side's got tennis balls in it. The other side's got golf balls. And I say, well, which of those would you like to have? And they go, I don't know. I said, you don't want the golf balls because that's the small dense LDL. That's when it penetrates the endothelium, goes into the subendothelial layer, and wreaks havoc, causing atherosclerosis and foam cells. The big ones, on the other hand, don't necessarily get through as easily. So if you have a lot of little ones, the second issue is LDL particle number. So the driving risk for coronary heart disease and heart attack is LDL particle number 1, and LDL size number 2. That's the LDL story. You can't get that on a regular profile. Second one is HDL. Well, HDL on a regular lipid profile is a static number. It tells you absolutely nothing. It doesn't tell you about the size. It doesn't tell you about how many particles there are, and it doesn't tell you about its functionality. So the latest discovery in HDL cholesterol is the functionality is what determines whether or not it's atherogenic or not. Second is HDL particle number, which is very important. Well, you don't get either one of those on a regular lipid profile. You get a static HDL, which means nothing. It can be low, it can be even high. And you see that number, you can make no predictions whatsoever whether that HDL is good, bad, or ugly, and whether it's going to be protective to the patient.
So you want larger HDL, right? That's more protective?
Well, generally, that's what we thought. We thought that larger was better than smaller. But it turns out that all of them are important because they all have a different process. And the real small HDL, they call pre-beta, that's the one that docks to the macrophages and other tissues to literally remove cholesterol, LDL cholesterol from the tissue and then take it to the liver and dump it. So you got to have all of them to kind of transport from little to medium size to big through all these metabolic pathways. So actually all the HDLs are important. And it's hard now, based data, because it's gotten complicated again, which size is better than the other.
Oh, that's really interesting. That's kind of new news.
It is new. It's the functionality. So here's what I'd leave.
And by functionality, it's producing reverse cholesterol transport?
That's exactly right. So RCT, reverse cholesterol transport, also called CEC, cholesterol efflux capacity, determines functionality. But the functionality of HDL is probably 100 different things. So there's like 100 proteins and lipids in HDL. And so if all of them are working good, it's totally functional. But if you knock half of them out, it's kind of limping along. If you knock all of them out, it's not doing anything. fact, HDL, get this, if you knock everything out, it becomes not only dysfunctional, it becomes pro-atherogenic.
Wow.
So now you can have an HDL that's actually inflammatory, causing heart disease. That's really bad. Now you got nothing protecting you.
And I think I've heard you say that if you have somebody that has like a super high HDL, there's an increased risk of that, right?
Yeah, if your HDL in a woman's over 85, most of it's probably dysfunctional HDL. And a male, probably if it's over 60. But there's actually, this is another new kind, just came out like 2 months ago. There's a U-shaped curve with HDL. So people have low HDL may be okay. People that are right in the middle, and then it goes up again, it gets worse. So at either end, you're probably looking at an HDL that may not be working. So it's kind of got to be at a certain number. I think in this study, it was like 32 to 35 was kind of the number that was at the bottom of the curve.
So do you measure HDL efflux, cholesterol efflux capacity?
There's a new test from Cleveland Heart Lab that does that. It's not available clinically yet, but we've been using it now for about 6 months in a couple of research trials. The name of it is HDL-FX, which stands for functionality. Cleveland Heart Lab has it. They're in phase B trials right now, and it probably will be out sometime in 2020 for the commercial use. That's all we've got for RCT right now.
You know, I talked to a Dr. Sri Ganeshan who has the Mito swab test, and I think that he's just come out with a cholesterol efflux test.
I hadn't heard of that one. I know the one with Cleveland is validated with clinical trials, and so as far as I know, that's the best one on the market right now.
Okay. So you mentioned LDL and HDL particles, and so normally we think larger is better. Now we find out with HDL that's not necessarily the case. But with VLDL, which most people don't talk about, actually larger is worse, right?
That's right. So VLDL is basically what people think of as triglycerides. But VLDL comes in all sizes too. And the big fat VLDLs are very atherogenic, but also they cause thrombosis.
Wow. So I'm not sure everybody puts a lot of importance on VLDL, but you're saying that we should.
Yeah, but when you see somebody who has high triglycerides or high VLDL, and it's the big fat one, concomitant with usually a low HDL, and then that group of people are usually metabolic syndrome, diabetes, obesity, and those people are the ones that have the discordance between LDL and LDL particle number. So here's what happens. You go to a doctor's office, he orders a routine lipid profile. Oh, your triglycerides are high, your HDL low, but your LDL is okay. Well, it's not okay because the LDL that patient has is a small dense with increased LDL particle number. That patient has one of the highest risks for heart attack of anything, and they're ignoring that. But yeah, all of these need to be treated. All the triglycerides, we use all kinds of things for that. Omega-3 fatty acids, niacin, if you're going to go to a drug, fibrates.
Can you talk about the importance of Lp(a) for heart attack risk? And there was a recent information about the Biggest Loser trainer, Bob Harper, who had a massive heart attack, and apparently elevated Lp(a) was his only significant risk factor.
Yeah, Lp(a) is genetic. There's very little you can do to change it. Exercise, weight reduction, eating better doesn't usually modify Lp(a) very much. So when you got this genetic type, you have to get a lab that knows how to measure it, number one, because many labs don't give a good quality measurement of Lp(a). So you get deceived into whether you've got a problem or not.
Really? So there's different ways to measure it.
Yeah, there's some measures mass, some measure different technology. So you got to find out whether your lab is consistent and has the best technique. That's number one. Now, assuming it's elevated, it's a matter of degree. 30 or less is normal. So incrementally over 30, the risk for heart attack goes up. If you're like 40, not too bad, but if it's 150, yeah, you're in trouble. And what Lp(a) does, it causes atherosclerosis, coronary heart disease, MI, clotting, retinal artery emboli, and aortic stenosis. So it's a bad actor. And there's not many things we have to lower it. Niacin and NAC are the two that seem to be the best.
And how much do you think it's reasonable to lower it?
Well, you try to get it down as close to 30 as possible, and it's hard to do that. But you're going to have to use high doses of niacin, high dose of NAC, usually put them on low dose aspirin to kind of help block some of the clotting effects. There's a whole list of stuff, Ben, that has been reported to lower LP(a). Right. Most of it's anecdotal. I mean, we've got vitamin C, carnitine, CoQ10. I mean,
yeah, there was a lot of people talk about this vitamin C thing. I guess there was one study on that.
Linus Pauling's protocol. Right. And it makes sense. I mean, the protocol basically stops the attachment, we think, of LP(a) to the vessel wall. But I can't find any data that Linus Pauling ever published that documents that in humans. Probably got some rat studies, whatever. But I've used it on people just because sometimes you don't have anything else you can do, and it's pretty benign. Vitamin C, proline, and lysine in right proportions.
Right. I had a patient who came in today, and in about a year, we got it down from 96 to 60 with niacin, a fairly modest dosage. And one time I had a patient couldn't get her LP(a) to budge, and I sent you an email. This is several years ago, and you said panathine and tocotrienols, and bam, perfect. It was unbelievable.
There you go. Well, like I said, there's about 15 things on my list for LP(a). When I get back into the wall, I start throwing whatever I can and see if it works.
Well, that worked unbelievable.
That's great. Good news.
How important is homocysteine? That's an often part of an advanced lipid profile.
Yeah, the protocol that we use has homocysteine on the advanced lipid test automatically, along with C-reactive protein. But homocysteine is a bad actor too. Most of the studies you read kind of poo-poo homocysteine. It's always not a big problem. Don't worry about it.
Homocysteine is a protein found in the blood that's independent of cholesterol as a cardiovascular risk factor.
It's very common with MTHFR, heterozygote, homozygote. Causes vascular damage, strokes, heart attack, vascular dementia, kidney disease, and it's elevated by a lot of things in your diet, plus your genetics. But the risk for homocysteine becomes dramatic at 12 and higher. That's when the curve shoots straight up. I like to get it below 8 in everybody I can, but if I can get it to 5, that's where the curve becomes fairly flat.
5, wow.
If you can get there. The risk at 8 is pretty low, but it's starting to go up. 12 through the roof. So if you see it over 12, you got to work hard to get it down.
And so to lower homocysteine, we're using methylated forms of B6, B12, B9. Are there any other nutrients that can be beneficial if that sort of B vitamin strategy doesn't get you where you want to go?
The cocktail, as you know, is methylated folate, B6, and all the others. And there's about 10 things in that methylation pathway. And there's, as you know, there are all kinds of SNPs you have to measure because it's not just MTHFR that can be the problem. And if you find out which SNP's missing, you kind of know which one to give the most of. So what I typically do is start with a balanced methylator, and I see what their homocysteine does. If I'm not getting there, then I'll order a methylation profile and start looking at all the enzymes, and then you can attack it directly.
Okay, good. So I'd like to bring up TMAO, and this is a marker for heart health that was developed by Dr. Stanley Hazen from the Cleveland Clinic.
Yeah, so TMA and TMAO, we'll distinguish what those are. Trimethylamine is a product that you get primarily in carnitine, maybe phosphatidylcholine, and then the bacteria feed on that stuff and they convert it to TMAO, which is trimethylamine oxidase, and that's a conversion in the liver. So the TMAO has been associated with blocking reverse cholesterol transport, along with other atherogenic effects. So Dr. Hazen felt that it was a risk factor for atherosclerosis, and therefore you should limit the consumption of things that cause TMA to go up. Well, there's a lot of controversy about that issue as well, whether it's cause and effect or whether it's just an association. But if you do consume a lot of carnitine in your diet and a lot of PC in your diet, you can raise TMAO. It's no question about it. But then there was a study from Mayo Clinic, because they're always butting heads with Cleveland Clinic, and they found that if you took carnitine, you reduce your risk of heart attack, even though your TMAO may have gone up. So, you got to balance all this stuff out. What I typically do, I measure.
And we know that L-carnitine is super beneficial for the heart, right?
Absolutely, yeah, particularly in heart failure. So it's not that you don't want to use it, and then you got to balance TMAO. But what I typically do, if the TMA goes up, I'll put them on a primarily plant-based diet for about a week or so, kind of get them cleaned up, give them some probiotics, some prebiotics, and then try to get everything back to where I want to. Because I use a lot of carnitine, taurine, and D-ribose in my heart failure patients. And if you stop the carnitine, for example, because that's transporting the long-chain fatty acids into the mitochondria for beta oxidation, you can end up causing them to do not so well.
And cold water fish contains high levels of TMAO.
It does.
So, we know how beneficial fish is and, how it lowers your risk for heart disease. So this whole TMAO thing really doesn't seem to accord with all the other things we know. Also, you're talking about choline, and we know how beneficial choline is for liver health, brain health.
Yeah. So I'm not sure I buy totally into the TMAO issue yet, because there's too many benefits of the things you just mentioned. Balance of the studies with fish, that doesn't pan out. So I don't know, really what the story is. That's one to find out about.
Well, one way that some people have analyzed it is that the TMAO is produced by the gut bacteria. And
right.
So it may just be a marker for having an unhealthy dysbiotic gut.
Exactly. So if you've got dysbiosis and the wrong bacteria in there, if you clean up the gut, and that's generally what a plant-based diet will do, and it'll convert very quickly, use a couple of days, get your microbiome cleaned up. The next time you challenge them with PC or carnitine, their TMAO won't go up. So I think the dysbiosis is a good explanation for it.
Okay, so now you've just mentioned the vegetarian diet, and so now the question is, what is the best diet to lower your risk for heart disease? Is vegetarian diet better, Mediterranean diet, ketogenic diet, or does it depend on each person?
If you go by science and published data, there's no question the Mediterranean diet is the best for heart disease and diabetes and other issues. And it's not a vegetarian diet. It's a plant-based diet, meaning you eat a lot of vegetables and fruit. That's at your base of your so-called pyramid. But you also eat meat, particularly fish. You just cut out all the refined carbs. A lot of omega-3s and MUFAs and olive oil and nuts in Mediterranean diet. So that's what I tell people to do most of the time. And then we'll throw in some fasting mimicking diets, some fasting stuff, and we get great results with everything doing that.
Okay. So, when I've looked at some of the studies on the Mediterranean diet, one of the confusing things is it's a little fuzzy exactly what it includes. I mean, we all know about olive oil and fish, but and fruits and vegetables. But other than that, it's, is bread included? Is pasta included? Is there a lot of legumes? Is what about cheese and dairy products? So it's, and if you look at the different studies, they all have different criteria. And this may partially be because it depends on which part of the Mediterranean. Is there really a Mediterranean diet?
Yeah, you're exactly right. When you say Mediterranean, you have to define what Mediterranean diet is. The one they use in Spain or Italy or somewhere else, and
right.
Greek. So sometimes it's better not to name a diet. It's better just to say, here's what I want you to eat. So let's just do that. 10 to 12 servings of organic, fresh fruits and vegetables a day, mostly vegetables, 8 to 4. That's the ratio, okay? High quality organic meat, cold water fish, salmon, mackerel, cod, complex carbohydrates, get away from refined carbs. And that's usually anything white, like bread, pasta, white potatoes, and white rice. And just make sure that your percentages of those things, a lot of monounsaturated fats, olive oil, and nuts, and a lot of omega-3s, both in your diet, but also as a supplement, because you just don't get enough just taking the food probably. And so if you do that, you don't really do a ketogenic diet, which is another thing I don't recommend, because it raises your lipids and causes inflammation, and it's just not a healthy diet for heart disease. Now, if you got a brain problem, yeah, maybe different. The problem is when you do the ketogenic diet, a lot of people get their saturated fats and other fats up really high, and then they don't get everything else balanced.
Interesting. So, patients who are heterozygous or homozygous for ApoE4, I often hear people talk about they need a special kind of diet from everybody else. What's your opinion about that?
Yeah, the ApoE4, are the ones that have a higher risk for coronary heart disease and Alzheimer's. They do have a differential response to what they eat, particularly different types of fats. And those are the ones who can really have a dramatic effect, particularly with saturated fats. So in that case, I would really augment them with omega-3s and monounsaturated, maybe reduce their saturated fats a little more, definitely keep them off long-chain fats, and no trans fats at all, 0.
Now, is that a group that you might put on a vegetarian diet?
Yeah, you could do that.
Okay. So you've also written about micronutrient deficiencies that can play a role in heart disease. And for those not in the functional medicine world, that seems a really strange idea.
Yeah, right. So most people are micronutrient deficient in something if you check it. And so let's just pick one, the micronutrient that's really common, magnesium. Well, okay. Magnesium is like 400 biochemical pathways. You say, well, would you rather treat every 400 pathway with something, or just give them some magnesium and be done with it? Well, how do you know if their magnesium's low? Well, you got to measure it. And as you know, magnesium is primarily inside the cell. So if you measure just regular blood magnesium, you don't know what their magnesium content is. So we measure intracellular magnesium. And we use a company called SpectraCell, which has the micronutrient testing, and it measures your intracellular levels in a functional way, which is much better than the so-called bell-shaped curve. Is how do you compare to somebody else? So you're measuring your own lymphocytes and what they need to be adequately functioning based on repleting the micronutrients is missing. It's about 30 things they measure. And we do this in everybody because it really fits right in with the disease. I've seen this happen over and over again. They come in and they've got high blood pressure and they're like 5 deficiencies missing, and we just replete their micronutrients and their blood pressure goes to normal. I mean, it's amazing. Pretty simple. Yeah.
Yeah. So with this understanding of heart disease, you mentioned immunological reactions and inflammation, which is an immunological factor. Essentially, part of heart disease is really an immunological mediated, really an autoimmune disease. And then when we start thinking about the other diseases, the major diseases, the chronic diseases, we know that cancer is immunologically mediated. We've got all these autoimmune diseases that are on the rise. And even when you look at gastrointestinal conditions, Dr. Pimentel has recently shown that IBS, which is one of the most common conditions, has an autoimmune component. It's apparent that you really need to take a broader approach, such as used in a functional medicine approach, if you really want to address heart disease.
Exactly. I tell everybody, if you understand cardiovascular medicine and vascular biology, it crosses all the boundaries, because those 3 finite responses, inflammation, oxidative stress, and immune dysfunction, as you mentioned, every organ has those finite responses. So in essence, inflammation in the brain, inflammation in the heart, those 2 circuits connect very quickly. And then the gut connects to the cardiovascular system. So if you don't get everything kind of lined up and get all those 3 finite responses controlled, you're not going to do well.
Okay, so let's talk about We've talked about diet. We've talked about advanced lipid profiles. I like to use some of our time to talk about nutraceuticals, or the use of targeted nutritional supplements. So what are the best supplements to use to reverse plaque in the arteries?
We've done now for the last 10 years a protocol for plaque reversal and plaque prevention, but also we can now reduce coronary calcium score, which people used to think you couldn't do, but we've documented you can.
Really?
Here's what we do. Omega-3 fatty acids, and you got to get high doses, 4 grams, 5 grams a day, and it's got to be a high quality that's balanced, DHA, EPA, GLA, and gamma delta tocopherol. Second is a compound that's got nitrates in it. You know, you can get a nitrate compound like Neo 40, beetroot extract, whatever, but it's a beet compound. And that supplies nitric oxide through a different pathway, very different from arginine.
Okay.
Kyolic garlic has been studied at UCLA, and vitamin K2 MK7.
Okay.
Now, the recent study has shown that you need a minimum of 360 micrograms a day.
360.
360, that's the new number.
And underdosing.
Yeah. So get a good quality, get it to that dose. There's a couple of other things we use. There's some very specific probiotics. Lactobacillus rhamnosus is good. And then luteolin, lycopene. So there's about 6 things that clearly reverse plaque. And then there's a few things we'll throw in for other people that have soft plaque versus hard plaque. But if you do that basic program, you're going to see some reversal.
And so you mentioned coronary artery calcification scan. What percentage of patients? So if you have a high score on that, for sure that indicates that you have plaque. But let's say you have a low score, you could still have plaque that's just not calcified, right?
Yeah. So let's talk about that because it is very confusing. High coronary calcium score, CAC, means 2 things. One, you've got calcium in the arterial wall, or you've got calcium in a plaque that's obstructing, and you can't tell which of those 2 it is based on the score.
So you can have calcium in an artery wall that's not part of a plaque?
That's right. And that's where you don't know how to predict whether they're high risk for obstructive coronary heart disease. And you have to do additional tests.
So why would a coronary artery have calcium in it if it's not?
Well, it's aging of the artery, number one, or it's got micronutrient deficiencies like the ones you mentioned, K2, MK7, D, and A. That's calcifying arteries, but your bone's not calcifying. So those 2 are at the opposite extremes. So when you see a calcium score, it's how you got to go to the next value and say, okay, is it in the artery or is it just in the wall? And you go exercise echo, nuclear scans, or you do arteriogram to find out. Now you're right on the other one too, which is if your calcium score is 0 or low, it doesn't mean you don't have heart disease because it may not be calcified in the artery. Okay, it could be, in the plaque. So I've had a couple of people who had like 95 block in their LAD, and they had a 0 calcium score. But it was soft plaque, it hadn't calcified yet.
Can you explain what the LAD is?
Left anterior descending artery is the widowmaker. That's the one that supplies the inferior lateral part of the heart. If it goes out, you're gone.
Okay. So how effective is red yeast rice for improving our cardiovascular risk?
Red yeast rice is a great product, and we use a lot of red yeast rice. Again, you got to have a high quality because a lot of it's come in from China. It's spiked with something, and a lot of companies don't make the high quality. So if you get a good quality, it works like a charm. We use really high doses in people that are like statin intolerant or just refuse to take a statin.
And high dosages is
48 milligrams a day.
Okay.
And we use it with berberine and some other things to enhance the effect. But
and
you give me
phenols, I think
LDL particle number, and they say, look, I can't take a statin because my muscles ache. If I get them on high dose red yeast rice, berberine, a phytosterol, and some niacin, I can get their LDL particle number down 50%, which is what most of the drugs will do.
Wow.
And there's actually data that red yeast rice will primarily prevent a heart attack and also secondarily prevent another heart attack if you've already had one. So the data is there. And actually, the Annals of Internal Medicine has written a couple of articles that it's a good alternative to statins if they can't take it.
Now, some people say that red yeast rice is really just the natural version of a statin. And if you're going to be intolerant to a statin, you're going to be intolerant to red yeast rice. And if you don't want to take a statin, why should you take red yeast rice? Can you answer
and none
that
of those
question?
are actually true statements. Red yeast rice was the compound that Merck Pharmaceutical used to make lovastatin. But what they did, they took everything out except one thing. So red yeast rice is a lot more than just a statin. Statins in red yeast rice, but it's not the whole answer. So when you give a statin, you're giving just that piece. If you give red yeast rice, you're giving a whole compage of things that are going to help cholesterol, but also heart disease. Red yeast rice actually reduces aneurysms. It's anti-inflammatory. I mean, it does a huge number of things. So red yeast rice is not a statin per se. And when you give high doses, because it's not just a statin, you don't get the same side effects you get with a statin. Rarely, even at that 4,800 milligram dose, do I get any muscle problems. I almost never get a liver problem. It's very well tolerated.
So do you always use CoQ10 with red yeast rice?
I use CoQ10 because anything that's remotely smells, looks, or tastes like a statin, it's going to lower your CoQ10 through that pathway, particularly get the high doses of anything. So you give a CoQ10 with it. What you do is you measure the CoQ10 level before treatment, and you start measuring it. And I like to keep the CoQ10 level over 3 micrograms per deciliter. That's what's really normal. Labs, it's all over the place. But obviously, if it's not above that level or starts to drop, you need to give them CoQ10. And it's not just CoQ10 that gets depleted by statins. There's 10 things that statins deplete. So you got to measure all this stuff and then treat it. That's why, in traditional medicine, most cardiologists, lipidologists, they give statins and they don't even know that they deplete 10 nutrients.
What are the 10 nutrients that depleted?
Okay, let's see. CoQ10, vitamin E, omega-3 fatty acids, tocotrienols, carnitine, vitamin K2, MK7, and vitamin K in general, vitamin A, heme A, selenium. I think that's 10.
Wow.
Yeah. And they all go down depending on the dose.
Amazing. So you mentioned plant sterols. Now, one of the companies that's doing advanced lipid testing is measuring whether you're a cholesterol absorber or a producer. And they're doing this by measuring levels of plant sterols. And so I'm a little confused if plant sterols are still a good idea as a result of looking at some of that data.
Yeah, we used to do that and try to base our treatment on that. It never did really work very well.
Okay.
Let me tell you why. So if you're a hyperabsorber and I block the absorption, guess what? The liver starts making more cholesterol. Now you're a hyperproducer. If you're a hyperproducer and I block that, guess what? You start reabsorbing more. So you're chronically chasing your tail. Best way to treat those people is just go ahead and block both pathways.
Interesting.
Yeah.
So meaning it would be helpful to use something that reduces the production of cholesterol by the liver, like red yeast rice, and then also use something like a plant sterol that helps block the absorption of cholesterol from
berberine. Did you know berberine?
Yeah,
berberine's great to block cholesterol. Plus, you get a lot of other great benefits. Do you know that berberine is an actual natural PCSK9 inhibitor? So you can go out and buy Repatha for $11,000 a year. You can buy some berberine for 30 cents a day. Yeah,
berberine's amazing. You know, it's also goes head to head with metformin. I use it as an anti-aging agent.
Yeah, well, it does. It actually turns off TOR. So it does everything you just said, plus a lot more. It turns on AMPK as well, which is good for the metabolic pathway and aging.
Interesting. So we talked about tocotrienols a little bit, but I also use them with the red yeast rice, or if the patient's taking a statin, tocotrienols will enhance the effectiveness of that, right?
They do. The tocotrienols are phenomenal agents, and I think probably everybody ought to be taking those. But here's how they work for cholesterol. They block production of the HMG-CoA enzyme through the messenger RNA, and then the other side, they break down the increased catabolism of the enzyme. So it's not a competitive inhibitor of HMG-A co-reductase. It actually reduces the increase that you get when you give reduced rice or statin. So you get about another 10% decrease in LDL, LDLP by giving a gamma delta tocotrienol at night with whatever you want to, because the production tends to be higher at night.
Interesting. So you mentioned niacin as a beneficial agent. I've had a number of discussions with primary care doctors, and they all tell me, oh, no, niacin doesn't do anything. There's no benefit. Why is there so much controversy about niacin?
Well, niacin got a very bad rap when two large clinical trials came out a few years ago. And Joe Pizzerno and I and several others, Mimi Guarneri, wrote scathing articles back to the journal saying, studies were terrible, you're misleading people, you have not put the nail in the coffin of niacin by any means, and here's the reason, and you should still be using it. So let me tell you, first of all, continue to use niacin. It works. And the reason it works is multifactorial. It not only makes every lipid parameter better. I mean, if I do an advanced lipid profile on you, everything I measure, niacin improves it. Everything. There's not one thing that goes wrong, including functionality of HDL. And then the only downside to niacin is if you give really high doses, you might increase your blood sugar, you might increase your homocysteine, you may flush, get a little rash, whatever. But typically, you can give a lower dose of an intermediate acting niacin and get really good effects that are beneficial for atherosclerosis. So everything prior to these two inappropriate reports that had bad methodology, niacin worked great. So keep using it. Just get a good quality.
Yeah, I think one of the studies used niacin along with a drug that blocked the flushing effect.
Exactly. That was Merck's multi-million-dollar drug, and the drug didn't work. It was supposed to stop the flushing. Now, I'll say this now because I can get away with it because the published studies out there. The drug that they used, they had done studies in experimental animals that suggested that it increased atherosclerosis.
Wow.
Now, they never said that, and they weren't about to say it that it does in humans because it was an animal study. But it was a little bit, shall we say, deceiving. Yeah.
So soluble fiber is there was a lot of talk about soluble fiber, and I should eat oatmeal. And what's the word on soluble fiber?
So you should eat a mixed fiber, soluble and insoluble. We never really understood why fiber works so great for everything, but as you know, it works through the microbiome. Fiber literally gets rid of a lot of the dysbiosis. Bacteria use it to make great chemicals to reduce diabetes and heart disease and blood pressure and cholesterol. Those little rascals do a lot of good job for us if we keep them healthy.
I guess the thought was that the soluble fiber would glom onto the cholesterol and take it out of your system.
Well, it might do a little bit of that, but it turns out it's probably most of it's through the microbiome.
Right. Okay, yeah. Great. Awesome. So I think that's the questions I had on my mind. What would you like to tell our audience in terms of closing thoughts, and then in terms of getting a hold of your books and or signing up for some of your programs?
Excellent. Thank you for asking. So all the books that I've written are on Amazon, so they're easy to find.
And Barnes & Noble, I'm assuming, as well?
Yeah, they're bookstores, Amazon. The newest one that's coming out is really incredible, up-to-date textbook of cardiovascular integrated medicine. And as you know, precision and personalized medicine is the key word now for everything. But This book we've got like 35 authors. I did the editing on the book, and it's the who's who of their specialty. So if you're a healthcare provider, this is the book for you. Watch it coming out. It's Walters Kluwer, probably December. Educate yourself and get the books and read them. But the second thing I would say you to do is come to some of the conferences that we do. A4M, American Academy of Anti-Aging Medicine. We teach an advanced cardiovascular course. We also teach a sort of an intermediate course as well. But module 16 is the advanced course, and it's basically like a master's degree, and we're giving dual certification now for people that complete all 4 modules. It's like getting a master's from a university.
Okay.
So that one's good. And then the other one we do at A4M is module 2, which is kind of the intermediate cardiovascular course. The advanced course is 4 24-hour courses.
Wow.
So it's 4 weekends at 8 hours a day for 3 days. So that's 96 hours.
Wow.
The other module, which is sort of the intermediate course, is one 3-day module that's 24 hours. So you can come in depending on your level of expertise to either one of those. We'd love to have you at A4M for those.
That's great. Are you still teaching for IFM as well?
Not so much with IFM as I was, 15, 20 years ago. Still do a lot with AIHM, Mimi Guarneri's group out in San Diego, which I'm sure you know about, and also with the Natural Medicine Conference that they do also in San Diego.
Great. Awesome. Thank you, Dr. Houston.
My pleasure. Thank you, Ben.